Now we're going to talk about ankle injuries in the emergency department and how we correlate the ankle x-ray findings with the clinical exam. When we think about ankle injuries in emerge, we all think of the auto ankle rules. The auto ankle rules, what do they tell us to do? You should feel the posterior 6 centimeters of the lateral malleolus. If they're tender, they need an x-ray. The posterior 6 centimeters of the medial malleolus. If they're tender there, they need an x-ray. So for the auto ankle rules, you palpate the posterior 6 centimeters of the lateral malleolus, and then don't forget the base of the fifth as well. And then over onto the medial side, it's the posterior 6 centimeters of the medial malleolus with also a palpation of the navicular. And that's what the auto ankle rules ask us to examine. Then what do? If they're tender in either of those spots, they get an x-ray. If they're not tender, we ask, hey, were you able to weight bear? And if you're unable to weight bear 4 steps immediately after the injury, and you're unable to weight bear in the emergency department, this also prompts an x-ray. What I'm going to do is I'm going to challenge you to think differently about the auto ankle rules. Because these rules actually have nothing to do with an emerge ankle exam. All they are is a really great tool for who does not need an x-ray. Once a patient needs an x-ray, they also need a history and a physical exam. When we look at the x-rays, what do we look mostly for? Oh, which is the mortise, which is the better view down that channel. And you can see of these two, the one on the left is the clearer view down the channel. When you look at this mortise, it's pretty obvious it's shifted out from underneath the tibia. That talus is way lateral. Here's another case. And if you look carefully, you got to measure the distance from the tibial plafond, the ceiling of the tibia, to the talar dome. And you compare that to the gap between the medial malleolus and the talus. And if it's off by 1 millimeter, you maldistribute weight by 42%. And this is actually, as mortise shifts go, this is actually relatively obvious. And if this one isn't relatively obvious to you, then it's going to be hard to pick up subtle. It means we need to do a little more work looking at these things. But this is a fairly obvious mortise shift. What I'm also going to do, though, is I'm going to challenge you to think about the x-rays differently. Because we spend a lot of time looking at the mortise, we spend very little time looking at the main film for orthopedic surgeons, which is the lateral view. The lateral view is incredibly important for all x-rays. We don't look at it nearly enough in the emergency department. Here's a patient who's injured her ankle. If you look carefully, you can see that she has a lateral malleolus fracture. The mortise isn't shifted. It looks pretty good. But look at the lateral film. And if you trace out the fibula on the lateral, just look at the posterior cortex. You will notice there's a big gap. This is significantly shifted. This is operative. And if you don't pay attention to the lateral, you can miss it. Sometimes those fibular fractures are only seen on the lateral film. So you need to trace out the fibula on the lateral. Here's a 50-year-old lady who's seen an emerge, injured her ankle, medial malleolus, non-tender. But when we look at her ankle x-rays, what do we find? She has a lateral malleolus fracture, suspected on the AP views, but look at her lateral film. Trace out the fibula. You have to look through the tibia, and when you trace out the fibula, there's her lateral malleolus fracture. What else does she have? Look really carefully. Now trace out her tibia. And in the posterior aspect of her tibia, she has a lucency. This is a posterior malleolus fracture. If you see a lateral malfracture and a posterior malfracture, that is a very unstable ankle, and it's very easy to miss this subtle finding. On the AP film, this is really subtle, but just measure the gap between the distal tibia and the talar dome, and compare that to the gap between the talus and the medial malleolus. This is subtle widening. The emerge doc diagnosed a lateral malleolus fracture, thought the ankle was congruent. The radiologist thought the same. This is subtle shift. The emerge doc examined her medial malleolus and it was non-tender, which is fine, but she's tender over her deltoid ligament. And this is part of the auto ankle rules that they don't ask us to examine, but it's a critical part of an ankle assessment. What happened to this lady? She missed follow-up. She was put in a boot. She comes back 2 months later to emerge. She has ongoing pain, but she never came back to the fracture clinic as she was supposed to, so this never got picked up 1 or 2 weeks later. And when she comes back 2 months later, look at her ankle. Look what it looked like before. Her ankle is destroyed. This is how unstable these ankle injuries are. She's totally destroyed her ankle. The only thing she gets now is either an ankle fusion or a new ankle. So you got to be very careful. That's a very subtle case, but it's why you need to look at the lateral film. What else is important? The history is important. Mechanism. This 45-year-old guy injured his ankle. But his mechanism was external rotation. His foot turned out. That's a huge red flag. Where is he tender on the exam? He was tender over his deltoid ligament. He was tender over the syndesmosis, the junction between distal tibia and distal fibula. He was also tender in his proximal third of his fibula. And if you took a history about external rotation and you examined him, then what you would have done is you'd have predicted that he needs an operation. But if what we do is we just take the x-ray and look at the x-ray, his x-ray didn't show us anything. It certainly didn't show this. This was revealed by his history and his physical exam. 22-year-old, injured her ankle, seen by one of our senior eMERGE residents, seen by an excellent eMERGE staff doctor, diagnosed with a severe lateral ankle sprain. The next day, the radiologist recalls the film and says, wait a second, that talus looks shattered. She comes back to eMERGE a few hours later after she was seen. She was sent home, it got recalled, and when she came back, you can see what a normal talus looks like. The ones in red are hers. She shattered her talus, but if you're not used to looking at it, it doesn't even stand out to you. When she comes back, she gets a CT scan, and she has destroyed her talus, and the talus has terrible blood supply. Easily missed. Why? Because on history, she axially loaded. An axial load is a big red flag mechanism. On physical exam, where she's tender, not lateral mal, not medial mal, but she's tender over the talus. It's the anterior part of the ankle. The auto ankle rules never ask us to examine, so we never touch, and we miss these clinical clues. So the auto ankle rules are a very good test to tell you who doesn't need an x-ray. But once you do an x-ray, it's not nearly enough of an exam. It doesn't ask you anything about history, and there are very worrisome mechanisms that you got to think about. So we want you to think differently about the rules. Don't just do the rules, order the x-ray, and tell the patient what's wrong. Do a history and do a physical. If the rule helps, then okay, you maybe don't have to do the x-ray. But if you need an x-ray, you need a history and a physical. And look at these lateral films. Look at them first, because we don't look at them enough. Look at them first and trace out the fibula. Trace out the tibia. Look for those subtle posterior malleolus fractures. Look at the talus. Look at the calcaneus. There's lots of information on a lateral film that we don't give enough credit to. So we examine the ankle, start in the posterior part, feel the compartments. You can do a little Thompson test. Get down and feel the Achilles. On the lateral side, there's a calcaneus. If that was a concern, the way to examine the calcaneus is to give it a good squeeze. Lateral malleolus, you can feel around here. If they were a snowboarder, they might be sore down here, and they could have a lateral process fracture of the talus. An important thing to look for. But the auto ankle rules don't ask us to examine. When you come over to the medial side, remember a very important landmark is the deltoid ligament. And where is that found? That's found below the medial malleolus. And it's a very important indicator because if they have a significant injury to their deltoid ligament, that's a medial malleolus equivalent injury. And as we come around to the front of the ankle, you can then feel the medial malleolus. There's a little soft spot of the ankle. That's the ankle joint. Above that is the distal tibia, which you can feel all the way across. And where the distal tibia meets the fibula on this side, that's where the syndesmosis is. The joint is here. What's below it? Below it is the talus. And the talus is down here. And you can palpate the talus as well. So as we can see, there's lots of areas of the ankle that the auto ankle rules don't ask us to examine. If the mechanism was an axial load, we'd worry about calcaneus, talus, the distal tibia. If the mechanism was external rotation, that's how you can disrupt the deltoid ligament. The force can come out, you can have injure the syndesmosis, and then the patient can have a high fibular fracture, so-called Maisonneuve fracture. But mechanism is really important. Again, the auto ankle rules don't ask us to worry about mechanism. So what's worrisome? Axial load. What's worrisome? External rotation. What's worrisome is medial ankle pain. Pay attention to these things. Way more important than what the auto ankle rules ask us to examine. The auto ankle rules are only there to tell us who doesn't need an x-ray. If they need an x-ray, they need a history and a physical exam. So as we wrap up ankle pearls, a few important things to think about. The auto ankle rules are very useful to defend not ordering an x-ray. But if you need an x-ray, you also need a history and a physical. Recognize the high-risk mechanisms. Axial load, big red flag. External rotation. And the auto anchor rules don't ask us to do that. As you saw in the physical exam, there are way more important areas than just the lateral malleolus and the medial malleolus. We need to examine those, otherwise we miss critical clues to subtle diagnoses. And when you do look at the x-ray, scrutinize the lateral first. We tend to ignore it. There's lots of very valuable information. Trace out the tibia. Trace out the fibula. Right? Look at the talus. Look at the calcaneus. Lots of important stuff that's easily missed. And then by all means, look at the mortise because it's really important to make sure that's intact. So I hope that helps you on your next shift. Thank you very much.